Welcome back to the ACP broadcasts. It was a pleasure today to hear some really exciting data that comes from the UK, the aTTom trial, about extended adjuvant endocrine treatment. And we've got three people to discuss this. We've got Chris Paul, flanked by Susie Cleater and Catherine Harper-Wynne.
Well, good afternoon. The final session of the plenary yesterday was Richard Gray's presentation of the aTTom trial. The aTTom data set had been much heralded. It's a trial that really opened to recruitment back in the mid-1990s, at a time when the standard of care in respect of adjuvant tamoxifen for women with early breast cancer probably wasn't fixed at 5 years. There was probably some debate even at that stage. And the trial was originally designed as a trial of shorter tamoxifen versus longer tamoxifen. And it was some way into the natural history of its recruitment before the design hardened out at 5 years versus 10 years. And even at that time, which was about 8 years ago, I think, that decision was hotly debated by the steering committee. So Richard began his presentation with some Oxford overview data relating to 5 years tamoxifen versus none. And he pointed out two salient things, really. In respect of recurrence after 5 years treatment, on this graph, you'll see that the recurrence curves are still diverging between the 5 and 10-year mark and only really become parallel after 10 years out from starting tamoxifen treatment. So this is described as usually as a carryover effect, meaning there's a continued progressive benefit from that 5 years tamoxifen between 5 and 10 years. So Richard's first point was that going beyond 5 years is really going to be a sort of a hard act to follow. And when the interim analyses of these data were first presented and were mostly negative over that first 5 years, many of us really wondered where we were going to go with these data. But it was Richard, God bless him, who over the years kept calm and carried on. Looking at the survival curves, this carryover effect is even more marked. And perhaps if we look at the survival curves in the right-hand panel, even after that first 5 years tamoxifen, the curves are still diverging, not just between 5 and 10 years, but between 10 and 15 years. So the study design was to take women with early breast cancer, and the eligibility at the time were very, very broad. They were not restricted to patients with estrogen receptor positive tumors. They could be estrogen receptor positive or estrogen receptor unknown. And after the patients had been on tamoxifen for 5 years, they were then randomized. So they weren't randomized at the outset to 5 versus 10. The randomization occurred after, in that subset of women who'd undergone 5 event-free years. And you'll see that 3,485 women were randomized to stop tamoxifen, and 3,469 were randomized to continue tamoxifen towards year 10. The trial was very, very, very simple. It was a Tesco trial. It was pilot high, sell it cheap, minimum data, 1 annual report form. And this is perhaps one of the criticisms of the trial, but arguably at the time, to run a trial of this size did require some considerable economy. 176 UK centres were involved, and from the outset, this trial was designed to be run in tandem with the ATLAS trial, which had exactly the same design, but which was run worldwide. Both trials were originally designed to pull in about 20,000 patients each. That's the truth of the matter. But aTTom, the interest in the aTTom question waned with the advent of the aromatase inhibitor studies, and latterly it had a hard time recruiting. But as time moved on with recruitment, a higher and higher proportion of women went in with demonstrably estrogen receptor positive tumors. Here are the results of aTTom in respect of recurrence. And on the x-axis, you'll see years from randomization. This is not years of tamoxifen treatment. This is years from the randomization point. And in the bold curve, the continuous curve, those are the patients continuing tamoxifen, and the interrupted curve, the dotted line, are the patients who stopped tamoxifen. The bottom lines really are that there were 580 recurrences in the continuing tamoxifen line versus 642 in those who stopped after 5 years. And this amounts to a risk reduction of 0.85, a hazard ratio of 0.85, with 95% confidence intervals that run between 0.96 and 0.95, and the significance value here is a p-value of 0.003. Since 2008, there have been an additional 143 recurrences in the continued arm versus 216 recurrences in those who stopped tamoxifen. Looking at the recurrences by year of follow-up, between years 5 and 6, you'll see that there's no apparent benefit at all from continued tamoxifen. And this is really, and even years 7 to 9, it's more modest. And these data are in contrast to the studies such as MA17, extended adjuvant therapy in the shape of letrozole after 5 years tamoxifen, where the curves diverge very quickly and very early. So there's a lag here in the benefit of extended adjuvant therapy becoming apparent. And it looks like that benefit is still increasing in that tiny fraction of patients who've been on, who are now 15 years out from the start of tamoxifen treatment. How come there's some patients 15 years out? Because the trial's been running that long. So these are venerable data in a sense. For mortality, we're seeing 392 deaths for those continuing tamoxifen versus 443 for those who stopped tamoxifen at 5 years. Again, for years 5 to 9, we're not seeing an advantage appear. The advantage only appears later, and for those later years, the hazard ratio is 0.75. For overall mortality data, as opposed to breast cancer mortality data, the difference in deaths is 849 deaths for continued tamoxifen versus 910 for the patients completing tamoxifen at 5 years. Again, we're seeing no benefit apparent during years 5 to 9, and the benefit of 0.86, the hazard ratio of 0.86, only really appears for the years beyond. So we're seeing that there's very little impact of extended tamoxifen on non-breast cancer mortality, and obviously that's very reassuring. So the key message comes from putting these two data sets together. Put together the data from the ATLAS trial, and ATLAS recruited again somewhere short of the original target of 20,000. ATLAS recruited just over 12,000 patients. Put alongside a shade under 7,000 from aTTom, we've got nearly 20,000 patients. That together they provide proof beyond reasonable doubt, as Richard said, that continuing tamoxifen beyond 5 years really does reduce recurrence over the following years. But this benefit only really appears after 7 years of treatment. Together, the trials also show a statistically significant reduction in mortality. And again, very little impact on mortality between years 5 and 9, but we're seeing something like a 25% reduction in year 10. The other point Richard made yesterday, which is, apart from saying that the benefits are incremental and one has to sum these increments, put together, comparing indirectly 10 years tamoxifen with none. For patients with estrogen receptor positive tumors, you're looking at a reduction in the risk of recurrence of 50%. And that's the I think that's the stunning message here, really. How good endocrine therapy is compared with fresh air when continued in this extended fashion for 10 years, and the fact that we're seeing very, very little in the way of additional problems. We've not shown you the data today in respect of the endometrial cancer risk. It does amount to something like 3%. There is a 3% risk of developing endometrial cancer from that extra 5 years tamoxifen treatment. So I think we're now going to move on to discussing these data, and I don't think those discussions are going to be straightforward for 1 minute. So, Susie, what do you think of these data? How relevant are they? I guess we've all got a little bit more of a focus on endocrine therapy now in patients who seem quite clinically of high risk, given the sort of the advent of Oncotype and some of the sort of decisions that are happening in the Optima trial. Perhaps we're seeing patients who are node positive, depending on endocrine therapy. So perhaps this focus isn't ill-timed, but how relevant is it going to be to your practice?
Well, highly relevant, I think. I mean, these are very exciting data. They've perhaps not been met with the kind of fanfare that you might get with a newer drug, but it's a relatively modest clinical benefit, but it's a survival benefit. Okay, it's taken a lot of numbers to demonstrate that benefit, but it's a treatment that's relatively non-toxic, it's cheap, it's going to be easy to implement, and for those women who are tolerating endocrine therapy and want to do all that they can to minimize future risk, they're going to want to consider it. Now, it's not going to be for everybody, because there are some women who struggle tremendously with endocrine therapy. We've got to consider how it's going. I mean, in the premenopausal setting, it's fairly straightforward because tamoxifen is the only drug we have. It's a little bit more complicated in the postmenopausal setting. How does it fit in with aromatase inhibitors? I'm not convinced that it will offer, we don't have any data to demonstrate that it offers a benefit over and above 5 years of an AI, or even over and above a switch policy, 2 to 3 years of tamoxifen and an AI over 5 years. But it is a real clinical benefit. It's a survival benefit, not just a disease-free survival benefit.
And what are you going to say to your patients about the downsides, about specifically the endometrial cancer risk, and how will you manage that in your clinical reality? What do you say to people about it?
So I think we have to remember that endometrial carcinoma occurring as a result of tamoxifen is something that tends to happen in older women over the age of 50, if not 65. So it's not really going to be a risk for the young women. It is a risk for the older women. The ATLAS study, which was a much bigger study, showed, I think it was a 0.2% increased risk for every 5 years. So it is a real risk. But there isn't, and there was even an increased mortality from endometrial carcinoma in this more recent study, but overall there weren't more non-cancer deaths in aTTom. So I think we can say it's pretty safe, really.
So we're seeing a reduction in possibly cardiac deaths.
Yeah, I guess it must be offsetting. The cardiac benefits must be offsetting the endometrial toxicity.
So Wednesday morning, when you go back to southern England, what are you going to do? How are you going to implement this? Do you think folk are going to be banging on the door?
Well, I think.
What are you going to do?
I think we've got a couple of issues. I think we have to address whether we're going to approach women who are slightly outside of the 5 years. Are we going to actually do anything and find those women? That's quite a difficult task to undertake in the UK. Certainly, we've had discussions about this when we've looked at the ATLAS data, and we feel that we will approach women who are coming up to that time point. And I think psychologically, women do need to know that there is a possibility of having long endocrine treatment. The whole approach to that, I think, needs to be thought about very carefully and put in a very positive light. So yes, we will be offering it to people who are approaching that endpoint of 5 years, and subsequently going forward, it will be in our strategy for their endocrine treatment for 10 years, and they will be informed of that very early on in their management pathway. So it can't become an issue of concern to them, because obviously the anxiety aspect is actually something we need to, I think, consider.
So we're all talking about this becoming a standard of care, and we're all talking about planning that. We're seeing the issue as being more straightforward, I think you said, Susie, for the premenopausal patients. And I think, Susie, you said things would be a little bit more difficult, a little less straightforward for the postmenopausal patients. What's your handle on the postmenopausal context and the use of AIs? Do you see AIs as hugely straightforward? Do you see these data as offering an alternative for some patients who are having difficulty with AIs?
Absolutely. I mean, we've all been in that situation where even the high-risk patients that we're offering upfront AIs, they get a year in and they still can't cope, and you've been through the whole lot. This will give them an opportunity to have an endocrine treatment and continue it on. And I think with the postmenopausal women, as Susie alluded to, I think we have a difficulty because we're going to have this anomalous group that will have had 5 years of an AI, but in theory won't be having any more treatment. And that is the issue, I think, is to, and certainly at St Gallen, they talked about extending on tamoxifen for 5 years, so you've got a similar group.
Certainly the discussant yesterday seemed fairly
yes.
happy with that.
I do think that's a jump, but it's one of those things you'll have to see what the majority go with, but you will otherwise have an anomalous group that will be having only 5 years of treatment.
But I think increasingly there are a group of patients who, when they come to the end of 5 years of an AI, start putting pressure on their clinician to allow them to continue on that treatment. And in a sense, I wonder whether I'd be happy about them switching to tamoxifen at that point for 5 years rather than continuing on an AI for 10 years. I mean, we don't have a great deal of data for either.
Turning it round, what about the compliance issue? That was something else that the discussant flagged up yesterday.
Yes, I mean, I think
compliance, is that an issue in
she talked about,
Sussex.
Kent, actually. Let's get it right. I mean, I think, what's brought out yesterday is that from observational studies and results to date, you've only got 70% compliance. This was a study group. One would hope that compliance is higher with it being a trial. So God only knows what we're going to have when we actually implement this, to the general population. But yes, I think taking in, the whole aspect of watching these patients, being aware of how we're going to treat them in the round, then we're going to have to look at these issues with clinical nurse specialists, contacting them, etc.
Okay.
Can I make 2 quick points?
Of course you can.
Premenopausal women and fertility, there hasn't been huge uptake of preventative tamoxifen in the US, and that's thought to be related to the fact that a lot of women don't want to be on a drug that means they can't conceive for 5 or 10 years or whatever. Yeah. And then the other issue is how we're going to, a lot of us have started going over to distant follow-up of our patients. How are we going to recall the patients that have been discharged at 2 years?
Have we got
and I think if we're going to go for longer tamoxifen as a standard, I think we're going to have to paradoxically be a little bit more liberal about fertility holidays in the middle, perhaps, too.
Yeah. And as was brought out yesterday, a break. It's not the end of the world to say to a patient, you can have a break, come back and think about it.
Okay, well, I think we've covered the points. Thank you for listening.